Good morning and welcome to this meeting of the Physician-Focused Payment Model Technical Advisory Committee known as PTAC. Welcome to the members of the public who are here and are able to attend in person, and welcome as well to those participating over the phone or over the live stream. Thank you all for your interest in this meeting. This is the PTAC's fifth public meeting that includes deliberations and voting on proposed Medicare physician-focused payment models submitted by members of the public. We want to thank the stakeholders who took the time and energy to submit proposals, especially those who are here today. Your hard work and dedication to improving our healthcare system is appreciated. Including the 4 proposals we will deliberate on over the next day and a half, we've received 25 full proposals to date and an additional 15 letters of intent to submit a proposal. This demonstrates the continued interest of physicians in applying their day-to-day experiences, knowledge, and expertise to payment reform, and we are grateful for their efforts. We're also excited because today 3 leaders within the Department of Health and Human Services will be joining us to make public remarks. Alex Azar, the Secretary of Health and Human Services, Seema Verma, the Administrator of the Centers for Medicare and Medicaid Services, and Adam Bowler, Director of the Innovation Center at CMS and Senior Advisor on Value-Based Transformation and Innovation, will also speak this morning. We are eager to hear their remarks. Each of them has also made time to speak with PTAC this summer so that we could better understand how our work as a committee aligns with the direction of the department. The Congress established PTAC to provide advice to the Secretary regarding physician payment models. We are grateful for the Secretary's joining us today to speak about how we can help him achieve his vision for value-based transformation and innovation. We are grateful for CMS leadership joining us today who will put that vision into action. In addition to the committee sessions with senior HHS leadership, the members of PTAC have been hard at work since our last public meeting in March. Our preliminary review teams, or PRTs, reviewed the 4 proposals we will discuss over the next day and a half and have been actively reviewing other proposals that will be deliberated at future public meetings. Our next public meeting will be held here in the Great Hall of the Humphrey Building December 10th and 11th. At that meeting, we will mark 2 years of being open for business to receive models from the public. We have also been exercising our new authority to provide initial feedback to submitters of proposed models, which was granted to us by the Bipartisan Budget Act of 2018. Initial feedback, when provided, is given by the PRTs and is at the discretion of the PRT reviewing a proposal. We have also been and are continuing to seek public comment on our processes. A request for public comment is posted on the ASPE PTAC website. In addition, the committee will hear from stakeholders tomorrow after we conclude our proposal deliberations. One simple reminder, to the extent that questions may arise as we consider your proposal, please reach out to the staff through the PTAC at HHS.gov email. Again, that email address is PTAC at HHS.gov. We've established this process in the interest of consistency in responding to submitters and members of the public, and appreciate everyone's cooperation in using it. Today, we will deliberate on 3 proposals, and we will deliberate on 1 proposal tomorrow. To remind the audience, the order of activities for each proposal is as follows. First, PTAC members will make disclosures of potential conflicts of interest and announce whether they will not vote on a particular proposal. Second, discussion of each proposal will begin with presentations from the preliminary review teams. Following the PRT's presentation and some initial questions from PTAC members, the committee looks forward to hearing comments from the proposal submitters and the public. The committee will then deliberate on the proposal. As deliberations conclude, I will ask the committee whether they are ready to vote on the proposal. If the committee is ready to vote, each committee member will vote electronically on whether the proposal meets each of the Secretary's 10 criteria. The last vote will be an overall recommendation to the Secretary of Health and Human Services, and finally, I will ask PTAC members to provide any specific guidance to ASPE staff on key comments they would like included in the report to the Secretary. A few reminders as we begin discussions of the first proposal. PRT reports are reports from 3 PTAC members to the full PTAC and do not represent the consensus or positions of the PTAC. PRT reports are not binding. The full PTAC may reach different conclusions from those contained in the PRT report. And finally, the PRT report is not a final report to the Secretary of Health and Human Services. Following this meeting, PTAC will write a new report that reflects the deliberations and discussions of the full PTAC, which will then be sent to the Secretary. It is our job to provide the best possible recommendations to the Secretary, and I expect that our discussions over the next day and a half will accomplish this goal. I would like to take this opportunity to thank my PTAC colleagues, all of whom give countless hours to the careful and expert review of the proposals we receive. Thank you again for your work, and thank you to the public for participating in today's meeting in person, via live stream and by phone. So let's go ahead and get started. The first proposal we will discuss today is the acute unscheduled care model, enhancing appropriate admissions, which was submitted by the American College of Emergency Physicians. So we understand that the Secretary is going to join us, so what we'd like to do is I'll start with myself, introduce each of the committee members and any disclosures, conflicts of interest that need to be made, and then we'll probably break for the Secretary's arrival. So I'm Dr. Jeffrey Baylett. I'm the Executive Vice President of Healthcare Quality and Affordability with Blue Shield of California, and I have no conflicts to disclose. Bruce.
I'm Bruce Steinwald. I'm a health economist here in Northwest Washington. I do some work with the Brookings Institution as well, and I have nothing to disclose.
Paul Casal, cardiologist and executive director of New York Quality Care, the ACO for New York Presbyterian, Columbia and Weill Cornell. I have no disclosures.
Hi, I'm Harold Miller. I'm the president and CEO of the Center for Healthcare Quality and Payment Reform. I do have a disclosure in 2015 and 2016, long time ago. I provided assistance to the American College of Emergency Physicians as they were first thinking about developing payment model concepts. One of those proposals that we talked about at that point was similar to the proposal that they have submitted for review by the PTAC. I was not involved in this proposal at all, but I am going to recuse myself from voting and from deliberation on the proposal because of my past involvement.
Good morning. I'm Dr. Grace Terrell. I'm a general internist that is part of the Wake Forest Baptist Health System in North Carolina. I'm also the CEO of Envision Genomics, which is a precision medicine company, and I'm on the board of CHESS, which is a population health management company. I have no conflicts to disclose.
Good morning, I'm Tim Ferris. I'm a primary care physician at Mass General in Boston. I'm the CEO of the Mass General Physicians Organization. I serve on the board of a for-profit commercial company, Health Catalyst, in Utah. I also serve on the board of the National Health Service in England. I have no conflicts with this proposal.
I'm Dr. Rhonda Meadows, President, Population Health Management at Providence St. Joseph Health. I have no disclosures.
I'm Bob Berenson. I'm an Institute Fellow at the Urban Institute. My only disclosure is that as a senior official at CMS a while ago, in more recent years in my current position, I have had professional interactions with ACEP, but not about this or any other potential physician-focused payment model.
Kavita Patel, I'm an internist in DC and a fellow at the Brookings Institution, and nothing to disclose.
Lynn Nichols, I'm a health economist. I direct the Center for Health Policy Research and Ethics at George Mason University, and I have no conflicts to disclose.
So good morning. Good morning, everyone. At this time, we're honored to have Secretary Alex Azar here today offering public remarks. The Secretary was sworn in as the 24th Secretary of Health and Human Services on January 29th of this year. He brings with him valuable experience from both the private sector and public sector, including prior service here at HHS as General Counsel and then as Deputy Secretary. We appreciate his combination of public and private sector experience as our work as PTAC resides at the intersection between government, the private community, and other stakeholders. The members of PTAC have had the privilege of speaking with the Secretary in June, a conversation that helped strengthen our partnership and helped PTAC understand his vision on value-based care and how our work can best move this vision forward. We're grateful the Secretary has taken time out of his busy schedule to speak here today. Please join me in welcoming Secretary Alex Azar.
Well, good morning, everyone, and it's great to be here with the PTAC, and I want to thank everyone for the opportunity to speak with you today and to address the PTAC. First, thank you for your work as part of this committee. It is incredibly hard work, and I'd also like to thank everybody who's outside of the formal institution of the PTAC who contributes to your work as well. I know that there are many people standing behind the actual members of the PTAC. You as members signed up for a complicated and time-intensive task because you care deeply about building a healthcare system that serves patients better and about the role that physicians play in that transformation. It's a significant time commitment. I know I've seen your work, I've seen the rigor of your analysis, and I see that the considerable expertise you bring to the table, and we're incredibly grateful for what you do. One of the priorities that I have picked out for HHS for us to focus on at the highest level, the most ambitious and furthest reaching, is transforming our healthcare system into one that pays for health and wellness rather than sickness and procedures. Mantras like that, and especially the term value-based care, are so common in healthcare circles that we don't often pause to consider what they should really mean. The outcome we're aiming for is pretty simple, though. Better healthcare at a lower price. But the question of how we deliver that outcome is much more complicated. There's been some progress on some of the tools that we need to execute this transformation. We have more alternative payment models, more coordinated care, and more value-based compensation than ever before, and that's thanks to some of the individuals whose paintings and portraits are up on the wall right there, starting with Mike Levitt, Secretary Sebelius, and of course the work of Secretary Burwell in driving forward this value-based transformation and the foundations of this bipartisan effort. But the results that we hope for have not always materialized. As just one example, we saw in the analysis that CMS released at the beginning of August that the burgeoning number of accountable care organizations have not delivered significant savings when all costs and incentives are taken into account. But notably, the best results that we've seen have been in ACOs that took on two-sided risk, where providers have real accountability for outcomes. We've also seen better results from physician-run ACOs as opposed to hospital-run ACOs, interestingly. Without real accountability, we're just offering bonuses on top of payments that may be too high already. That's why we've now proposed, through the Administrator Verma's work, to simplify the ACO system into two tracks, requiring them to take on risk much sooner. And as our CMMI Director, Adam Bowler, put it last week, if this means somewhat fewer ACOs, then so be it. We need strategies and models that provide better care at a lower price, not just new models for the sake of new models and not new systems of payment for old systems that aren't open to real change. In some cases, as I've said before, that's going to mean mandatory models from CMMI and other mandatory reforms. Requiring participation can be necessary to determine whether a model really works, but it may also be necessary to meet what we see as an urgent need for reform. I'm impatient. I think our whole system is impatient. We need the change. We need it now. We need it quickly, and so we need your support for it. But we're not going to be overzealous in determining how these reforms happen. We're interested in driving the outcome that we want rather than micromanaging how to get there. Let me give you an example. I've got a relative who is currently in a rehab hospital, and I was sitting there with him, and one of the nurses came in and started complaining, knowing my job, started complaining to me about CMS's staffing ratios. I sort of scratched my head, and I just have a natural instinct on these things, and I scratched my head and I said, what the devil do we have to do with telling facilities their staffing ratios? It was just sort of a natural, immediate response. You know, we take the oversight of healthcare facilities very seriously at CMS and at HHS. It is important. We must insist on quality. But if you talk to any patient about what they want from healthcare, it's not process, it's outcomes. The outcome that we want for my relative at that rehab hospital is that whenever he is done with his care, he walks out rather than is in a wheelchair. It's a pretty simple measure. You ought to get paid if you achieve that, and he can walk out, and you ought to get paid less if he can't walk out when we're all done with the course of care. So that's really what value-based care means to me, at least. We need to tell you the what, better care at a lower price, and we're going to reward you for delivering it. But how you deliver it needs to be up to you. We also want to take a broad view of how providers can take on risk and earn rewards for good outcomes. This means not just episodic bundles where providers can take on risk. That's important, and that does satisfy an important need where we have episodic care. But we also need longer-term, longitudinal models where real rewards will be paid for keeping patients healthy and out of high-cost care settings. To oversee these efforts, earlier this year, the administrator and I appointed Adam Bowler as our senior advisor for value-based transformation and innovation, in addition to his hat as the head of CMMI. You'll hear him discuss later today the 4 Ps of driving toward value: making patients into empowered customers, making providers into accountable navigators of the health system, paying for outcomes, and preventing disease before it occurs or progresses. CMMI will soon be launching new, bold models that fall into these areas, and we hope you use them as guideposts for your work on PTAC. Getting better value from our health system and paying for value requires empowering patients to be consumers. But realistically, and I do think we all recognize this, patients are going to need physicians to help them navigate the complex healthcare system as learned intermediaries. And we need to give those physicians the right incentives to guide patients in making choices that will lead to good and positive outcomes. We are very interested in ideas that can help our physicians fill this critical gap. Without physicians playing a key role, the transformation that we need for American healthcare will never be possible. And PTAC's perspective, therefore, is absolutely critical as we drive towards value. A number of the models that have been advanced by PTAC have significantly influenced models that we have in the works, but working with all of you, we want to go much further. As we work on the transformation that I've described today, Adam, Administrator Verma, and I see PTAC as a crucial avenue for ideas and input. But PTAC is more than that, too. You all are really advisors to me, helping me to discern what needs to be done to make physicians' ideas a reality and inform HHS about how we can help. All physicians interested in putting forth ideas to deliver better care at a lower price are going to find an attentive ear from Adam, Administrator Verma, and from me, and from the entire Trump administration. I know all of you are interested in those goals, so I look forward to a close partnership with you in the years to come. And thank you again for having me here today, and I hope you have an exceptionally productive meeting today. Thank you so much.
Thank you, Mr. Secretary.
Sorry,
No, I understand.
I went up to the hill. I'm sorry.
I get it.
Thank
No,
you.
please. So I'd like to now introduce Administrator Seema Verma for the Centers of Medicare and Medicaid Services. She was sworn in on as the 15th Administrator of CMS on March 14th of 2017. Administrator Verma is an incredibly experienced healthcare policy professional. As the architect of the historic Healthy Indiana Plan, she helped create and implement the nation's first consumer-directed Medicaid program. She's also made it a priority to collaborate with PTAC, speaking and spending time with us about how our work fits into the CMS's ongoing efforts with value-based care. At this time, please join me in welcoming Administrator Seema Verma. Thank you.
Thank you, Jeff, and thanks for inviting me here today. It's a pleasure to be with you. As you heard, Secretary Azar has made it very clear that value-based transformation is the top priority for HHS, and CMS is very committed to making this vision a reality. So when we're looking at the area of value, and you heard the Secretary, I think, articulate what value is, delivering quality outcomes at the best possible, the lowest cost. And so at CMS, we're starting not only thinking about models, but thinking about how do we remove barriers to providers delivering value to the healthcare system. So it's not just about payment models, but there's many things that are standing in the way of innovation and providers delivering high-quality care. One of the things that he mentioned, which we're very focused on, is regulatory burden. Last year, we started an effort called Patients Over Paperwork. We put out RFIs, and we heard from literally thousands of providers. We went across the nation talking to rural providers, we talked to urban providers, and we went to a variety of different settings. And we heard some of the common issues that providers are facing in terms of regulatory burden. Some of the things that we heard about were measurement and quality measurement and the burden of having to report all of these measures to CMS. And so we created another initiative called Meaningful Measures. And just this year, we've taken out 100 measures across CMS quality reporting. And what we have found is that a lot of the measures that are out there are process-oriented. They're not outcome-oriented. They're taking a lot of time for providers to report. And so we've started, this is just the beginning of that process. We'd like to get to a point with our quality measures that providers don't have to do anything actively, that we can easily get that information from electronic medical records, that we can get that information from registries or claims data. And so we're going to continue our work on addressing some of the concerns around quality measurements. We've also taken effort on E&M codes, for example. We're working through, we put out a proposal and we're looking for comments on how we can address some of the day-to-day burdens that providers are facing. Also looking at Stark Law and a variety of different issues, all sort of premised on the idea that regulatory burden is preventing our providers from being innovative and from delivering high-quality care. So that's one piece of it, and the other piece of it, obviously, is looking at how do we pay for value and creating new models. We're very excited to have Adam's leadership in CMMI, and one of the things I've asked him to do is, as we're looking at models, to think about how we can include the patient in that as well. It's very important, obviously, that payers are aligned and providers are aligned, but actually activating the patient in that, I think, is very important as well. So what you'll see from us over the next year is efforts to include the patient. We're trying to empower our patients to seek high quality and value care. And in order to do that, we need to give them the tools that they need, whether it's issues around interoperability, whether it's having more cost data available to them, and also quality data. So we're looking at trying to create more transparency across the system so we can empower our patients to seek high-quality, value-based care. One of my main concerns, however, is we're looking at where we are today in terms of providers in the value-based system. We have only about 14% of providers in the Medicare program today that are taking on risk. Now, from my perspective, value doesn't always mean everybody taking full risk. And what we want to create is many opportunities for providers to participate in value-based models, but understanding that not every provider is going to want to take two-sided risk. So we want to create as many opportunities as possible. But the more risk a provider takes, we want to also create incentives to do that by providing more waivers from a lot of those regulatory burdens that stand in their way in creating innovative, high-quality care. So you're going to see, again, more models from us. I'm concerned that we don't have enough models, and that's why I'm particularly very supportive of the work that PTAC has done. This year, you're going to see us focus on some of the models that PTAC has recommended. We're focusing on some of the highest cost areas in the healthcare system, so we're looking at end-stage renal disease, cancer care, chronic disease, individuals with serious medical conditions. And a lot of the work that PTAC has done has informed the development of these models. So we really appreciate your efforts. I've always said that the best ideas don't come from Washington, and we need to hear from providers on the front lines. As we're developing models, it's really important to understand what's going to work and what's not going to work. And the PTAC's particular experience is very important to us. We recognize that that's a crucial component to us developing models. So we're excited to continue the work. And just echoing what the Secretary said, we really appreciate all the work that's been done. We recognize that you are volunteers, and the technical assistance and the insight that you've provided us has been very helpful, and you're going to see a lot of that, a lot of your expertise included in the models ahead. So thank you for your work.
Thank you, Administrator Verma.
Everybody's leaving me.
It's okay, Adam. How's your chair feeling?
It's good.
It's good. Okay, very good. So I now have the honor of introducing our next speaker, Adam Bowler, Senior Advisor to the Secretary for Value-Based Transformation and Innovation, CMS Deputy Administrator and Director of the Center for Medicare and Medicaid Innovation. Mr. Bowler brings with him extensive experience with many innovative ventures across multiple facets of the private healthcare industry, including healthcare technology, laboratory management services, and healthcare analytics. He founded and led one of the largest home-based medical groups in the country, Landmark Health. Mr. Bowler became CMS Deputy Administrator and CMMI Director in April of this year, speaking with PTAC in June and July to share his vision for the Innovation Center and how he will engage with the PTAC. Please join me in welcoming Mr. Adam Bowler.
Thank you, Jeff. Someone told me last night that a mark of power in Washington is how simple your title is, and so from that perspective, I'm powerless. Thank you for inviting me to my first PTAC meeting. You just heard from the Administrator and the Secretary about our commitment to value-based care. And as Director of the CMS Innovation Center, and as Secretary's AZAR's Senior Advisor for Value-Based Transformation and Innovation, I'm going to spend a little bit of time talking about how we're planning to achieve it, and then how that relates to the critical mission at PTAC and how we're going to work together. First, Secretary Azar mentioned the 4 components to HHS's value-based strategy. We used P's, 4 P's, to make them easy to remember. The first is patients as empowered consumers. We're interested in using transparent and competitive markets to promote access and choice for our patients. We're interested in making our patients and the American patient first on our agenda in everything that we do. Second, physicians as accountable patient navigators. We want to create new arrangements for physicians to take accountability for their patients, whether that's in primary care, whether that's in specialties. And we want to empower the physician community. We want to take away burden that doesn't add value and let physicians focus on their patients. The third P is payment for outcomes. We want to modernize what are outdated payment rules sometimes and pay for results. And then finally, prevention of disease before it occurs. Our system today operates in silos. Medical is siloed from housing, from food, from social services. That's not how you would set up the system if you were designing it today. And we're interested in breaking down those silos to the benefit of Americans. Physician-focused models and the work done by PTAC is critical to this strategy and driving this strategy. The purpose of the CMMI, the Center for Medicare and Medicaid, our innovation center, is to create models that lower cost and improve quality. That's simple. So when I came, I spent a lot of time initially with my team looking at our existing model portfolio. We wanted to learn what worked and what didn't work. So we went through with a fine-tooth comb, and we said, these models are not reducing cost as much as we wanted to, or not improving quality. How can we improve them? or should we end them? And we did that. And then there were some that we noticed had great results, and we doubled down on those, and that influenced our decision-making as we thought about new models. In new models, we started to identify the elements that have made us successful in the past. And qualitatively, there are three things that kept surfacing. Models that were transparent, we were open about sharing data. Models that were simple. Healthcare is complex. And the best way to create models that people can depend on and drive care is to simplify it as much as possible. And finally, accountability. We need to empower our model participants to succeed, but then we also need to hold them accountable for that. I'm excited about the different internal ideas that have come to me, but most excited about those external, by a number of the ideas that PTAC has brought forward to us, by other ideas from stakeholders, by people in the audience, that can achieve the greatest impact. And I'll tell you, we're pretty myopic on our focus. It's what is going to improve quality outcomes, lower cost, and drive choice for the American patient. I'm proud to say that we introduced our first model under my tenure. It's one focused on, it's called Integrated Care for Kids, and it's focused on the opioid crisis. It's our first model in the opioid space, so I'm excited to announce that, and there'll be multiple others that we'll announce soon. In my tenure at HHS, I've been here close to 5 months. I've had the opportunity to interact directly with PTAC, with the members, and appreciated that opportunity. And I wanted to be clear that I very much appreciate the work that PTAC has done in the past and what they'll do in the future. Both the administrator, the secretary, and I are committed to working with PTAC. We're eager to implement the models that are proposed, and we're eager to evaluate them in terms of ability to improve quality outcomes, reduce cost, to drive a transparent, simple, and accountable future. I also want to be direct, because there's been some question as to our commitment, that we are working very aggressively on several models that have been pushed forward by the PTAC and recommended by the PTAC. These are several models that are focused in important areas: chronic kidney disease, primary care redesign, serious illness. They're active, and they're directly based on the work of PTAC. We're using PTAC's thoughtful analysis and comments from the stakeholders, including RPA, AAFP, CTAC, AHPM, to inform and drive our work in those areas. We're speaking to those stakeholders directly on an ongoing basis, too, to continue to develop those models in areas that PTAC recommended that we develop those models. I've been personally impressed with the rigor of the PTAC work and appreciate their recommendations. We've also had conversations recently with the Icahn School of Medicine at Mount Sinai and the Marshfield Clinic about services delivered in the home, a personal area of passion for me, given my background delivering home-based care. CMS has benefited directly from PTAC's recommendations and comments on proposals. I recommend that prospective physician-focused models continue their work with PTAC, because PTAC's recommendations will weigh very heavily on this administration. I'd like to thank PTAC for your ongoing hard work and commitment. You all have day jobs, and yet you spend so much time here because of your interest in advancing healthcare for our country. And I really appreciate that. I'm very much looking forward to the input from today and tomorrow's meetings, and from future input as well. So thank you for having me.
Thank you, Adam. We're going to take a 5-minute break and then rejoin the meeting. Thank you.
Produced by the U.S. Department of Health and Human Services at taxpayer expense.